Committee, Healthcare Committee is back in session. We are going to go to H96, an act relating to increasing the monetary thresholds for the certificate of need. We have three witnesses that will be with us this morning. And we will start off with Jonathan Reynolds. If you can introduce yourself to the committee and provide your testimony, it would be much appreciated.
Great. Good morning. Thank you so much. My name is Jonathan Reynolds. I am Vice President Clinical Ops here at Rutland Regional. I am joined here today by my colleague, Mitch Baruti, who is our Chief Legal Officer. I just want to say thank you for the time to offer the testimony this morning for H96. Just as background, I started here at Rutland Regional Medical Center 17 years ago. I'm a pharmacist by training. In addition to my clinical oversight responsibilities, I have twice served as the interim vice president for facilities and currently serve in that role right now. The blend of clinical oversight and the experience I have with facilities, I feel like provides a unique perspective into the CON process, which I hope to provide this morning. I've been intimately involved in the last two certificate of need applications that Rutland Regional has submitted. In 2021, our MRI replacement, and just a month ago, our linear accelerator replacement. We submitted that application in January for replacement of the machine that provides radiation treatment to oncology patients. I personally wrote about 95% of that application myself. I'll start by saying that Rutland Regional very much supports H96 as it is written, as the current thresholds of $1.8 million for replacement equipment and $3.6 million for construction are pretty low and easy to trigger in this day and age. And really that's because of inflation costs, but also anytime we perform construction within a hospital building, not only are we renovating the space itself, but we often have to go back in time and bring certain pieces of that construction forward to meet current guidelines. So collectively, it just becomes a very expensive process. Now, as I mentioned, our last two CONs that we submitted were a replacement for equipment that essentially manufacturers came to us and said, look, these pieces of these devices are so old that we are no longer going to support them. And that's because you can no longer get parts. They became cybersecurity threats. And these fully depreciated assets needed to be replaced. Our MRI project was $3.1 million. Our linear accelerator project was $4 million. That's currently out for review. The MRI machine, we perform around 6,000 scans a year. Our linear accelerator, we provide almost 6,000 radiation treatments to patients in our community a year. And the point being here, and I say this very respectfully, to go through the CON process is challenging. There's a lot of work for it. And the question I would ask is, these two devices, these two examples, the MRI and the linear accelerator, would we ever really not replace those? Patient care would be impacted so significantly, not only because of the lack of access in our Rutland community area, but across the state, because those patients, our patients in our community, would have to travel significant distances. So the point being, I'm just challenging the thought process of replacing existing equipment. There is a lot of work that goes into that through the CON process, and I'll go into that now. So the CON process can be very costly and burdensome. It demands many hours of time across the hospital. So not only does that increase costs, but it also takes many individuals away from a focus of patient care. So just to name some, a CON process involves finance teams, construction managers, contractors, architects, engineers, data analytics teams, directors and leadership of these service areas, including physicians. To complete these certificate of needs, it takes a village, and we depend on many folks within the hospital to contribute to these in order to submit them accurately. Now, additionally, as the CON application is a regulatory document, there's legal consequences associated, and this is filed with a verification under oath. This means that these documents must be reviewed by attorneys and all statements must be backed by facts. This also increased costs associated with the process to ensure that we're submitting something that is highly accurate. Now, these two past CONs, the MRI and the linear accelerator, show why we feel at Rutland Regional that H96 is very helpful. If this bill were to pass as currently presented, it would be a much smoother process to replace these pieces of equipment the next time around. Now, I will give another example of a hindrance that the certificate of need process causes us. And I'm going to go through a little bit of an example here. So bear with me and please ask questions if it's unclear. But our birthing center here is located a hallway down from our women's and children's unit. This means that once a patient delivers, the parent and the baby are moved from the birthing center down a hallway to our women's and children's unit. Now, this is a setup for poor patient experience. If you can imagine, the patient delivers, is recovering, and then we have to move the individual down the hallway to another unit. Patients have reflected numerous times that this just provides a poor experience, and we're looking to improve that. However, most importantly, though, because those two units are separated, we have to staff those two units with two different pools of nurses, LNAs. And those two staffing pools contain the same type of cross-trained nurses, but still, nonetheless, it's two sources of staffing costs between them. Additionally, providers must travel between the two units. And really, this just is an example of where we're lacking operational efficiency within our organization. Now, in looking to change that, we are in the middle now of planning to combine these units into a single unit. And we would utilize a labor, delivery, recovery, and postpartum model that's known as LDRP, where essentially from admission to discharge, you deliver, have your baby, recover, and then when it's time to go home, you would stay in the same room the entire time. Now, this keeps parents closer to the newborn. It's a better patient experience. Individuals do not have to travel amongst two units. But most importantly, by combining these two units into one, we can consolidate staff resources. We can use fewer staff, and we estimate here at Rutland Regional that we could decrease labor costs by almost $1 million by combining these two units. We are currently nearing completion for these plans of this construction, and this, in its current state, this project will certainly trigger a CON. However, instead of beginning and looking to start the construction process to take advantage of these labor savings, we're now beginning to allocate resources to prepare for the CON process. In the construction world, as you know, there are considerable wait times for many materials, including some of these that are highly specialized for healthcare. Instead of beginning to look at locking those in and scheduling contractors, we are now pivoting and we're moving towards creating a letter of intent. Then we will work towards the CON application, and then we will wait for approval and answer any follow-up questions there might be. The point is that the CON application significantly delays the start of the construction. I would wager that the CON process would delay our start of this consolidation of two units by at least a year, if not longer. And it could be little less, could be little more. I'm just saying it's at least a year that this is delayed. So this means that we have to wait to streamline staffing and reduce expensive contract labor, such as nursing travelers. So I want to point out that, yes, this is a lot about the money, but so much is about the inability to plan because we don't know how long the CON process will take. In addition to that, depending on how long the CON process takes, these projects could land in different capital years, or different fiscal years. So we have trouble even putting these capital expenditures in the correct budget because it's unknown as to when these projects will be approved. So what this all means is that specific to this project in our birthing center and women's and children's unit is that Rutland Regional is handcuffed and we are unable to take the initiative right now to decrease the cost of healthcare because of the CON process. I'm happy to answer any other questions that you have this morning, but I hope that just provides a few examples of why we support H96 as presented, not only for the replacement of equipment, but also for other projects, excuse me, that Rutland Regional is looking to begin.
So what you were just talking about, can you point to where in H96 that would essentially expansion of a existing unit? Can you just point us where in this bill it would address that? Just so I can flag it.
Yep. So I'd have to, and I might punt to my colleague here, but I know that there's the capital expenditure related to the CON increase to $10 million. That's where that would cover us. So I'd have to,
Okay.
I'd have to get back to you in terms of specifically where in the bill that is. But for sure, it is in there and that covers us.
That would be in section, that's 8.1 of the bill.
Thanks,
Okay.
man.
And just because I don't know the prices of anything, it seems like, would that be under $10 million?
It would. We are estimating now that consolidation is right around the $5.5 to $6 million amount. And granted, that could change and fluctuate, but we are in support of the bill because that $10 million gives us the breathing room to perform these types of projects. Absolutely.
Great. Thank you. Any questions? Lori, Woody, and then Topper?
Thank you, Jonathan. So just two questions. One, the savings that the $1 million savings is on staff. Is that a one-time savings that you project or yearly savings?
No, thanks for the question. That would be a year-over-year savings compared to what we would do now. So we would see those savings carry through in our subsequent budgets in years to come.
Okay. And on the two machine examples you gave, do you have how much it was to go through the CON process versus just being able to buy a new machine?
I'd have to follow up with you. I'm sorry, I don't have that information.
I'm
But
just curious.
it's a hard number to tackle because the fingers creep in so many different areas in terms of who's involved. But we could provide you some rough estimates.
That's okay. Don't worry about it. I just
Okay.
wanted to see if you knew. Thank you.
Sure. Yep.
Yes. If we vote this particular bill out of committee, it goes to the floor, it passes the House and the Senate. Would that save you time? Would this bill, as approved, would it save you time and money for your project this year? Or is
Oh,
this?
absolutely.
It
100%.
would.
Yep. Yep.
So
We
you
are-
wouldn't have to wait, a year or so until it was implemented. You could start right away with what you wanted to do.
Correct. Just in full transparency, we are still drawing up, we're finalizing the plans. We're working with end users. We are, I would say a month or two out from completing that work just to make sure that the construction plans are dialed in and encompassing everything that needs to happen. But the beauty of the relief that this bill would provide is that we can then jump right into working with our general contractors to begin scheduling this work. Otherwise, it's sort of put on the back shelf and we have to just keep an eye on that and drag our general contractors through into a future point where like, okay, well, now we have the approval to move forward. So that is why, to answer your question a bit more specifically, we feel like this is if this bill passes, we can allocate dollars in next year's capital budget and begin on this right away.
Yes, does Act 250 impact this at all?
In terms of the examples that I provided, Act 250 does not apply. But I'm sure that there would have been other CONs that Rutland Regional or other hospitals have participated in that Act 250 would impact, but not specifically either of these three that I spoke to today.
All right.
And phoning friends, in the development of this, of all of this language, was there a conversation about what the Green Mountain Care Board should do after the bill is passed that recognizes, applications that are in process? And I'm wondering if we should consider that, like, hear from the Green
Yeah,
Mountain
I
Care
was
Board.
looking, so the
about-
effective date of this is July 1st, 25.
Yeah,
And yeah, to see if it would be retroactive to
The first.
things that are currently in process.
yeah.
We can talk to the Green, yeah, we'd have to talk to Green Mountain Care Board, I think, on that. Leslie?
I'm not sure if you want to do this now or another time, but I'm curious if the HCA might want to look at that project through the lens of their recommendations. Where would it fit? And that's my curiosity, but I'm not sure if you want to ask if they're now or another time.
Why don't we ask them to put the glasses on as they're listening and then, maybe,
It's just an opportunity. It's almost like a case study. You know, this would be a case study of how to look at it through your lens.
any other questions? Oh,
I guess I have one.
yeah.
In terms of staffing, you see that having an impact on what you're talking about?
Yeah, absolutely. So Mitch and I work closely with our chief nursing officer to, especially with the birthing center consolidation. We have travelers across the organization. I can't quote you the current number, but it's anywhere in the 60 to 70 number. And a project like this, especially in the birthing center unit, which is a specialized type of nurse that we seek for that, we would absolutely be able to eliminate some of the traveler positions that we have associated with this. And that's where a lot of the cost savings comes from.
Thank you.
Great. Well, thank you. Thank you for
Great.
coming in and sharing your current and future CON.
Absolutely. Really appreciate the time and the opportunity. Thanks, everybody.
Thank you.
Thank you. So we're pivoting now to Hayden DeBlois, who's a fellow, and has asked to speak on this. Welcome, Hayden.
Yes, thank you so much for having me. Can you all hear me okay?
Yes,
Yeah.
and if you could give us a little bit on your background, that would be wonderful.
Certainly. Thank you so much for having me here today. Hayden DuBois. I'm a visiting fellow at FGA Action, which is a nonprofit organization focused on advancing a number of common sense reforms, including in the area of healthcare. Just for the record, previously, a Vermonter, grew up in Bennington County, went to Middlebury College, lived in Montpelier for several years, worked for Governor Scott actually for a number of years. So always happy to have the opportunity to be able to speak to issues of significant public policy importance in Vermont, and I appreciate the opportunity. With that, I'll keep my testimony relatively brief, and I'd be more than happy to answer any questions, but I've worked on certificate of need reform in a number of states around the country, and I'm here to strongly speak in favor on behalf of FGA Action in favor of H96. As you know, H96 would substantially adjust the thresholds associated with certificate of need laws in Vermont. And as you already know, these are essentially can be thought of as something akin to permission slips that medical institutions need in order to establish, expand, or in some cases even purchase expensive equipment. For far too long, independent research has established that Vermont has some of the more restrictive certificate of need laws in the nation. Meanwhile, a number of states from California to New Hampshire either don't impose certificate of need laws at all, while others impose minimal requirements. And over the last several years, there's been a national sense of momentum in increasing some of the monetary thresholds and decreasing some of the regulated categories associated with certificate of need. The Mercatus Center at George Mason University has done some pretty robust research on this and found that Vermont's current certificate of need laws uh, because of the thresholds with which they kick in and the amount of regulated areas they cover, they unnecessarily increase healthcare costs, limit competition, and in fact worsen health outcomes. So by increasing the certificate of need thresholds as H96 would do, Vermont would not only promote competition in its healthcare marketplace, but likely lower costs and improve access for all Vermonters. So for all those reasons, I think this simple, common sense, bipartisan legislation is a really strong step in the right direction towards a more affordable and accessible healthcare system in Vermont. And I would hope that the committee would advance the bill. And I'd be more than happy to answer any questions.
Yes, Woody.
Could you give more information on the George Mason report? What is the site called again?
Yep. So it's the Mercatus Center at George Mason University. They did a study entitled Vermont and Certificate of Need Programs in 2020. And they produced a spotlight essentially on Vermont's Certificate of Need laws. In that study, they issued a number of findings, and I'm just pulling it up right now in front of me. So some of their key highlights were that they think by reforming certificate of need requirements in the state of Vermont, it could reduce per capita healthcare expenditures by $228 per person in Vermont. By reforming certificate of need laws would increase the number of facilities and would improve health outcomes in major indicators of mortality and post-surgical outcomes. So they produced a pretty robust study. I'm more than happy to send that around to the committee if that would be of interest. That goes into a little bit more detail.
Nice.
That would be nice. Thank you, if you could. I think it's hyperlinked at the bottom of your written testimony.
Oh, you know what? I think it is too. So that might be the
I
best way to.
think your citation at the bottom.
Yep.
So as this is a, certificate of need is something that you've looked into, and I don't even know what it's referred to. I just keep calling it reverse CON.
Yes.
And others, and I know that other states have mechanisms in place where if facilities want to close certain services, that they have to go through a process to do that. And I wondered if you had any data on that or even thoughts on that in general.
That's a great question, Madam Chair, and I appreciate it. I would say, based on my experience working on this in other states, the overwhelming majority of the issues and the contention and the discussion around this is not pertaining to the question of certificate of need requirements as it relates to closures of facilities. It's almost entirely focused on opening or expanding those facilities and to what extent other actors in the healthcare arena can, engage in hearings or other forms that would limit the ability of new providers or existing providers to expand or open facilities. The closure side hasn't been as much of a point of contention, and I think is more easily moved through the process, just based on my own anecdotal experiences than the opening or expanding side of the equation.
And I'm wondering if you had the opportunity to hear testimony earlier from our chief healthcare advocate's office.
I missed that. If you, what was there a summary, if you don't mind?
I think in particular, I'm thinking about the idea that maintaining different tiers at different levels that would trigger CON and the requirements that facilities always take Medicaid and Medicare. If you had any national data or thoughts on that.
So a couple thoughts on the different levels and different tiers, so to speak. The existing certificate of need thresholds, as you know, vary in Vermont by whatever the service is. So there's a wide number of existing triggers that exist. I think establishing some uniformity at higher levels by consolidating the number of thresholds is probably a simpler move and a one that would probably add simplicity to the process. But the main issue is just raising the thresholds so that fewer expansions or openings would hit that trigger, so to speak. The second part of your question about, I believe, was about, acceptance of patients on Medicaid, for example. Not as much context on that. I think obviously Vermont has a fairly significant portion of its insured population covered under the Medicaid program. There's a nationwide problem. I mean, I can tell you from nationwide data, the Medicaid and CHIP Access and Payment Commission has produced some pretty frightening statistics as to how many individuals nationwide are having difficulty finding primary care providers, specialty providers at facilities. So ensuring that they have access is fairly important. But I would argue that reforming the certificate of need laws in this manner would increase the number of facilities that would enable them to find a place for treatment or for access. So I think this would actually help expand the number of options that those Vermonters would have, if that makes sense.
Yeah, it does. Thank you.
Sure.
Any other questions? Yes, Woody.
I'm just looking over that article. And I noticed that there is, besides a limited repeal, there's also some verbiage on a full repeal of cons. Could you address that for us today?
Yes. So ideally, in an ideal world, a full rollback is doable. I think there's well over a dozen states in the nation that are operating and have operated without certificate of need requirements of any form. However, I think the provisions contained in H96 are a very reasonable sort of middle ground to think about if the legislature wanted to at a future date look at a full repeal. It leaves that door open. It doesn't close it, but it gets you to a point where at the very least the monetary thresholds aren't too restrictive as they are now. They're giving providers, whether they're new or existing, some more breathing room and some more capacity to expand and open new facilities without having to worry about getting that permission slip. So full repeal is something that's been pushed. Again, telling you from my personal experience working on this in other states, Montana, for example, they recently, about 2 years ago, had major certificate of need reform. They didn't go for quite a full repeal. They went for almost a full repeal. They repealed the certificate of need regulation in a number of areas. They left it in some other areas and just raised the thresholds, as Vermont is considering doing. And based on encounters and experiences I've had with lawmakers since then, they've felt like that was a really strong approach that worked well for them. So I think the provisions in H96, even if not a full repeal, would go a long way towards achieving the goals of a more affordable and accessible healthcare system.
Yes, and those that have done a full repeal, can you address that as well?
Yeah, so there haven't been as many that have done full repeals. What it is there are a number of states that have just simply never adopted certificate of need requirements at all. They were never operating with them, and so they've continued to operate in the absence of certificate of need laws for as long as these laws have been around. So there's probably only a handful of states that have done really a full repeal, but in those states, and again, I'd have to refresh my memory on the data. I'm not aware of any adverse outcomes or issues that have arisen to the point of raising a serious question as to whether or not we should be pursuing those rollbacks. Again, the national momentum over the last 5 to 10 years has really been in favor of strongly reducing the number of certificate of need restrictions.
Thank you.
Sure.
Thank you. Thank you for your perspective and lots to think about.
Thank you so much. I really appreciate your time, and thank you again.
Thank you. So I think oh, what
I can give a quick answer.
would you like to come up?
Don't think I need to, but
Take
sure.
take the glasses off that you put on really quickly and.
Oh, Superman.
Mike Fisher, healthcare advocate. Again, just quickly, I'm not sure we captured all of what was discussed in the Rutland project, but at least a significant part that we did capture, we did hear was a replacement of depreciated equipment. And so under this proposal and with our support would be exempted.
Okay, and it was a combination of two units.
Yeah, well, there was the proposal, which is actually in S10, which is the Senate bill, that the Green Mountain Care Board recommended as an exclusion, which was for equipment that has been depreciated and needs to be replaced. So obviously, if there was a need for it before, it doesn't work anymore.
So you're saying you can fall exempt.
It's exempt and we support that
In your
exemption.
model. Got it.
Yes.
Thank you.
Uh,
Appreciate that.
Since you
Sorry,
haven't,
can I follow up
Mhm.
on that? The other thing they were talking about though is the realignment of their floor.
Yeah.
So don't know if you heard that part,
we did
so,
not hear that part.
Okay,
So-
yeah, that.
so, yeah, so there's a birthing unit, right?
Mhm.
So someone gives birth, they have to be moved to the other end of the floor.
Mhm.
They're looking to combine everyone in one. It would reduce staffing $1 million a year, but it would trigger, right now, it triggers the dollar amount.
So there's somewhere between the current trigger and the new proposed triggers.
Right.
And this, so thank you for the question, because this is a perfect example of the kind of project that we don't want to get in the way of. And so, if the committee is interested in moving forward with this concept of a lower tier, fashioning that and asking the board to contemplate how to fashion that in such a way that it would be a simple, easy, maybe assumed to go forward without any intervention from the board, something like that.
Can the expense with, not with the tiers, but looking at
Hmm.
bill is written, which it would be construction, development, purchase, renovation, or any capital expenditure by or on behalf of a hospital for which the capital cost exceeds. And then Green Mountain Care Board and the bill is introduced, both say 10 million.
Right.
So conceivably, it would still fall under, or do you think it would cost, I don't know.
He said
He
five.
said under.
You said
Yeah,
five.
He said
Something
under
like
10
five, yeah.
million.
Said it would be under 5.
Yeah.
Under 5, it was 4.
And if I could just spend a
You can.
second responding to the concept of reverse CON.
Yes, I forgot to ask you about that.
So this is tricky, is my answer. I think given recent events, I certainly understand the desire to have a review of decisions to reduce certain care, facilities reducing care. In my mind, this is really a hospital budget exercise. It fits in my head much better. I can see you clearer if I put my glasses back on. It fits better in that construct for me. I think there's some question about whether the board feels like it has the authority, exactly whether they have the authority to really accomplish that. But it would seem to me like the board in its review of hospital budgets could be empowered to say, hey, we want you to come back with how you're going to comply with our hospital budget order, and have the authority to give some input on that. It's really tricky because I also really think that as a concept that our regulator needs to sit significantly higher in the process. The Green Mountain Care Board doesn't know how to run hospitals. Green Mountain Care Board is never going to know how to run hospitals or healthcare facilities. And so I think the board's job is on a higher level to say, okay, here's how much money we have. Here's our budget. Here's what we can afford or we think we can pay for. And not get into the nuts and bolts of this versus that. And we have to hospital leaders who can make those decisions. And then I'll pivot back to, I understand the interest in the question given recent decisions.
But yet I'm not saying, there's all this conversation around global hospital budgets, which is essentially saying, here's your budget and here are the services you need to provide. Within that budget, these are the essential services, just like we do with our benchmark plan. These are the essential items that you must cover. I think I'm more thinking about this reverse CON process in terms of that if let's say your net patient revenue comes from, 90% comes from other things, that you can't just go and say, we're losing 1%, so we're going to shut down our primary care or our 8 mental health beds. Great, and give me one moment. And I just didn't know how you felt about that protection. I'm struggling, maybe I'm editorializing here, or maybe opening it up for committee discussion. I'm struggling with the bill in the fact that it's very clear that we need to do something to transform our CON process. I think everybody is in agreement of that. And yet we don't want to go to the Wild West. And what can we do as a committee, and what can we do with this bill to free up and allow for competition of services that are accessible, affordable for Vermonters, that spur competition, which I think will bring costs down and give patients options for lower cost services, and yet also protect, I'm going to call them consumers, but I call them patients, can protect Vermonters from predatory practices, or how do we balance that?
So those are the balance points. I guess I will push back a little bit on the competition being the answer to our healthcare affordability problems. When the Green Mountain Surgery Center put out its application, how many years ago? 2015. So this was before I was at the HCA, but I came in just before the decision, so it took a long time. The HCA ultimately weighed in favor of it because we felt like it provided Vermonters with another option and a lower cost option, and that outweighed the concerns that were being offered by the competitor, UVM, who was saying that this was going to take away revenue from them, that it's going to cut into their business. And but it's and in my opinion, this is 10,000 years ago, but in my opinion, I thought that the hospital was overblowing its concerns, overstating its concerns. For sure, really complicated surgeries still have to happen at UVM, and UVM still has to be staffed for that. And so we don't want to take actions that undermine our system. But my point in telling the story is that it's not a simple evaluation. It's complicated. And so I think at the end of the day, it took too long. But at the end of the day, we supported the Green Mountain Surgery Center and the UVM Surgery Center much more recently. But really because of consumer interest, and because in our evaluation, we didn't believe that these projects would undermine the system. But I guess I say all that to say it's more complicated than just competition. I always say this, there's a corner in Philadelphia where there's 3 hospitals on 3 of the 4 corners. I think the 4th corner is owned by one of those hospitals. But between those 4 corners, I mean, you literally have 3 hospitals, you know, a couple hundred, you know, 100 yards away, 100 feet away. I understand in an environment like that where competition, you know, where one hospital can say, I'm going to do this, I'm going to do it cheaper, and I'm going to attract people. Like it, that makes perfect sense to me. If you're sitting in the corner of a city with 4 million people or whatever. How many people are in Philadelphia? But in Vermont, where we have in Vermont, it's harder for me to contemplate. And I think we always also recognize that everything we build is going to be paid for with ratepayer dollars and healthcare dollars.
Do you feel that the experiences of, for example, the Green Mountain Surgical Center has just essentially scared other people away from even proposing something?
Well, I mean, I think that the experience of how long it takes to go through this process is unreasonable. And so I don't know the answer to that, but I got to imagine if you're looking at it and you're looking at what other people experienced and you saw that it took 1.5 years or 2 years or 2.5 years, I don't know what it took. It took a long time, that would dissuade people. And that's really exactly why, well, that, and also it's a tremendous amount of work for people at the board and my office and the applicant, that we're suggesting a tighter time.
And since we're in just sort of casual discussion, do you want to say something?
I was just gonna
Susan,
point out something about your CON comment, the ahead model does include service line. Going out there.
Oh, did you want to identify yourself?
Oh, Susan Ritson,
Okay,
Vermont Health First.
thank you. Leslie, do you want
I
to?
just want to clarify between the conversation to be had about this reverse CON idea and where that's going to sit. Because I heard, you know, is it in the bill? Is it in the budget? What are our goals? Because I think what you said is really important in that if we're going to lose service lines, it has to be for the right reasons and not for not right reasons. And so far, feeling a little shaky on that. So
It doesn't live anywhere right now.
that's what I'm wondering. Do we want to put it somewhere? Yeah, where do we want to put it somewhere? And the question for me is where?
Yeah.
And that's what I'm looking for
And
a
I-
conversation about.
And let me answer on the highest level. I think the concept is important and it should live somewhere. We should make sure that the board has the authority to do that kind of a review.
But possibly as their hospital budget review.
But then would we need to, if I may, then we haven't given them necessarily authority. I mean, where do they get that authority?
From you.
Right, so we would have to include that.
So we'll ask them next time we have them in here whether or not that's,
Where and what they need.
Yes.
Yeah, so I just want
we'll
to
get their thoughts on that. Okay.
If we're gonna do it with the hospitals, I think we need to do it with other people too.
Well, we don't regulate anybody else.
But people have to go through a CON process.
Mhm.
We don't regulate them, but they still have to do
We
it.
don't regulate anybody else's budget, like, yes.
So are we saying that essentially if you've gone through a CON process and you have essential services that are regulated, or are you just talking about anyone that's gone through a CON process? That you would then need,
We pick who, not see, but. Yeah, go ahead.
yeah, I mean, I think, I'm thinking about things like we have all identified everybody acknowledges primary care,
Mm.
mental health care. I'm not looking to stop somebody from retiring. And, if we're talking about things like that, we would be talking about, say, an FQHC that has, 10 providers at it, and one of them decides they want to retire. They're reducing services if they haven't been able to hire somebody else. So I'm not sure. I'm thinking about things like, oh, they have to go through a process to be able to have them retire.
No, I'm not
No, you
talking
can't.
about-
You're not going there, nor would I.
I'm
Yeah,
not
I'm not
talking
going
about-
there.
Not a service
Yeah,
line.
I'm thinking, I'm trying to get at what you're thinking about.
I'm thinking that if you're talking about reducing services, that we should figure out how to make sure that those services continue if they're necessary in the area. That's what I'm talking.
Yeah, I'm thinking about that all, if we granted, say, Green Mountain Care Board authority in their hospital budget review to have the hospitals come back and, you know, present their proposal of how they're going to meet those obligations. And then the Green Mountain Care Board would then conversely have to be able to say, okay, well, we don't agree with that. What can we do so that you don't cut those? I mean, there would need to be an alternative. It's not as though they can just say, nope,
Walk away.
too bad.
Yeah.
Keep
Okay.
on- I mean, there would need to be something.
Yeah.
That we would give the board the ability to, you know, modulate.
Yeah, okay, let me tell you why I did that, why I said what I said. In central Vermont, we just lost a mental health unit. And that is affecting the people.
Mhm.
And so there should have been some kind of a transition plan to provide those services some other place, not just, oh, if someone wants to pick it up, they can. Type thing.
It is that unit that has this in my head. Ugly.
What's in my head
And,
too.
and what can we do to give the authority to the board to say, what's your plan? Okay, your plan is to close that unit.
Yeah.
And what can we do to ensure either to give permission that, okay, you can close it? Or because there's no need, or to say, let's come up with, you know, some alternatives so that you can meet our requirements while at the same time keeping this unit open.
Well, that's the
Should
reverse
we-
CON.
that's what I'm thinking.
Committee discussion things.
I'm sorry, what?
Are we discussing it now, or do you want to add it
Oh.
to the committee discussion agenda?
We can add it to the committee discussion agenda, but we had 30 minutes, so I'm just. Lori has something to say.
I think it's a great idea for several reasons. One, if we give the board the authority during the hospital budgeting process to have a conversation and have input as to how a hospital may have to reduce some service lines, I think it helps them have a better understanding of our statewide system, which I keep harping on is really, really important, and stop looking at each hospital individually. I think it also is beneficial for the hospital to hopefully be able to have an open conversation of, you're saying this, right? You're giving us this. This is what it means to us. And then again, looking at the statewide system, being able to see where the effects will be. I think it's absolutely vital as we move forward with any transformation we're trying to do in our system. And to make sure, to your point, both of you, that primary care and mental health are focus of the state and that we shouldn't be cutting it.
And I can think of other services as well.
Absolutely, yes.
Home health.
Well, here's another one. What if the surgical center decided they were gonna close their doors now? What would that do? That's why I meant it isn't just hospitals.
I think we're in agreement. And if I look at the lay of the land about how our healthcare financing system is doing and the costs of the care that Vermonters, cost of care today in Vermont, we have a number of really tough decisions that I think everyone at this table will hate. But nonetheless, really tough decisions in front of us, and they should be made as much as possible as decisions.
And as soon as we can too. Waiting for years and years, it's gonna be a tough nut to crack, I'll tell you. Because what's gonna happen to the people that need the service?
Collateral damage,
I-
collateral
Yeah, but
damage.
that's what made me call, but it's not.
Yeah, I mean, that's what breaks my heart,
appropriate.
right? That's what breaks my heart.
Okay. Thank you, and thanks everybody for today. Lots to think about. We're gonna take this back up. I think Friday?
Yeah.
Yeah, Friday. I